sorry, I forgot. Sorry, thank you. Okay. And then we can also talk a little bit about medications if you're interested, because eventually people are going to need some medications. But we're also going to talk about how do you take care of folks, older folks without medications, and particularly their behavior problems and any psych issues that might come up. And then finally, we'll talk about support and resources that's available in the community, not only for the elderly person, but also for you and for your family, because dementia really is a disease or condition of the family, more so than for the patient or for the elderly person. All right, let's get started. So we'll start off with the first case. 73-year-old evangelist who develops tremors and an unsteady gait. He goes to Mayo Clinic and gets diagnosed with Parkinson's disease, and they start him on Sinemet. Unfortunately, though, the Sinemet didn't help that very much. Afterwards, he starts having bladder accidents and becomes more forgetful and confused and becomes more and more depressed. So, question for you all, what kind of medical workup do you think he would need, and what kind of testing would help? What do you think?
Well, why is he having urinary incontinence?
Wow, why is he having urinary incontinence? Good question. What do you think?
No, I mean, that kind of medical workup.
He could have a UTI.
Okay, you could have a urinary tract infection. Okay, that is very common with people with dementia, particularly towards the end. But he's still relatively early. I mean, he's just starting to have memory problems. Yes, ma'am?
Could it be a side effect of the medication?
It's a possibility, right? So, could be a side effect of the medication. Although Sinemet doesn't, the Parkinson medications don't usually cause bladder problems. There are a couple that can, but usually early on at low doses is not supposed to be happening.
I would be curious about the family situation. Is
Okay.
that person stay at home with family taking care of this person, or he's in an institution being taken care by,
All right?
that may be related to depressed or.
Okay, so it's a very good question. Yeah, he's actually a well-known international evangelist. I don't know if you actually recognize this guy. By the way, anybody know who this person is?
Oh. He's still alive?
No, he's not alive anymore.
No, it's Billy Graham.
It's Billy Graham. This was Billy Graham. Okay, actually. So yes, he had a whole bunch of resources and support at home,
Yeah.
much more than the average person, right? Did I see another hand? I missed over here.
I forgot what I was going to say.
Oh, it's okay.
Oh,
You
we
can
should
do
see
that.
a neurologist to
Okay.
have workup done, and
Well, what kind of workup would you think he needs from the neurologist?
I don't know, does he have, is he developing Alzheimer's? Is he
Okay.
imaging done?
Okay, so he might need imaging done to look for
Plaques in his brain?
plaques in his brain. You're thinking of Alzheimer's, okay? Actually, when we do imaging, it's not usually so much to look for Alzheimer's, although there are some tests that can suggest Alzheimer's, which we'll come back and talk about. But I saw a hand over here too. Yes, sir.
Yeah, I wouldn't pass up that UTI issue. I've
Okay.
seen it cause a lot of memory problems.
Yes. Uh-huh.
Rapid onset.
Usually rapid onset, and we'll come back and talk about that as well, okay? Yes, ma'am.
I'm getting kind of very narrow here, but
That's fine.
are there tests that can show you whether Lewy body dementia is present or not?
Very good question. The answer is no.
Okay.
Lewy body dementia is still what they would call a clinical diagnosis. It's usually not that hard to make the diagnosis if you have a doctor who knows what they're doing. Unfortunately, most primary care physicians don't, and so it's frequently missed unless you see a specialist.
Because the Parkinson's started ringing that bell for me.
Okay.
I work in senior ministry, and
Mm-hmm.
the folks I know that have had Parkinson's can also, that may tie together.
Okay. Good point. We'll come back to that as well in a couple of slides. Another hand back there?
Yeah, my father was very clear-minded until he was probably 93, 94 years old. Then he forgot, he doesn't have the
Term memory, yeah.
short-term memories. Is that considered dementia or is different?
Okay. So let's talk a little bit about that. I'm going to jump ahead a little bit, sort of to the definition of dementia. Okay. So the definition of dementia is not just a memory problem. So there is some normal decline of our memory with aging. Okay. But to have a diagnosis of dementia, you have to have significant enough cognitive decline to impact your social function. Okay? Plus, you have to have another, what we call domain, right, other than memory loss. So we have different parts of our brain that sort of affect or control the different parts of our cognition. And we'll come back and talk a little bit more about that, about testing. But that's one of the ways, for example, we differentiate the different dementias. Okay? But anyways, you have to have at least 2 domain impairments, memory plus something else. So if somebody just has a little bit of memory problem, they wouldn't necessarily be diagnosed with dementia. There's a pre-dementia condition called mild cognitive impairment. Okay, which, again, I don't know your loved one, but he might have qualified for that if the memory problem was still relatively mild. Yeah. Any other questions about that? Okay, so the reason I bring this case up is because Billy Graham actually ended up having a condition called normal pressure hydrocephalus. Yeah, and I'm bringing this issue up because there are conditions that can look like and mimic dementias. There are a cluster of conditions that we call pseudo-dementias. Okay? And again, part of the definition of dementia is that it's an irreversible, progressive, neurological decline of the brain. It's a neurodegenerative condition, okay? Irreversible by definition. Okay? So these conditions, though, are reversible, meaning we can stop the progression of the damage to the brain, and so these technically are not dementias, but they can look like them. Okay? So the treatment, for example, for normal pressure hydrocephalus is putting in a brain shunt. Right? You get a brain surgeon to put it in a drain, okay, that goes down to the belly. And this is why, for those of you who followed Billy Graham's ministry, he actually went off his ministry for like 2 or 3 years. Okay? He got the procedure done, and then he came back. All of a sudden, he was back on the national stage, back doing his crusades. Okay? And this is why. And so it is important to get that medical workup, okay, and not just assume that all these folks have Parkinson's or Alzheimer's or some other dementing condition. Okay. The other condition that's, again, eminently treatable is neurosyphilis. So, for example, when I used to work in geropsych units, I would diagnose 2 neurosyphilis cases a year. And again, these typically were generally older women. And I'm not trying to be sexist here, but the reality is that what typically would happen would be that men would go off on their business trips and they bring the syphilis home, and they wouldn't tell their wives, but they would go get treated. And so grandma then would develop neurosyphilis 20, 30 years later, and families would be shocked when we tell them that their syphilis test came back positive, because they would swear that grandma's always been faithful, never had Yeah, but then what did Grandpa do? You know? So, yeah, it's usually Grandpa who brought it home, okay? And so Grandma never got treated. You know, she had a little bit of, vaginal irritation. That's the only syphilis symptom she had. She thought she just had a yeast infection, right? That went away a couple of weeks later. So she never knew she had gotten syphilis and never got it treated. So that treatment is with high-dose IV penicillin. You know, we start with a couple of weeks and then see how their response is. Sometimes people may need 4 or 6 weeks of treatment. Vitamin B deficiency, yes sir?
And you said that all of these conditions will appear as dementia or produce the same?
They will look just like dementia, right? The memory loss, the cognitive decline, the functional decline. And so that's why you need to have the workup to make sure that there's not a treatable reversible condition. Okay? And these are the ones we tend to look for. Because these are the ones easiest to treat. Now there are some other ones, but those are sort of more difficult, and not as common. But like for example, B12 deficiency is very common because as we get older, our stomachs have more difficulty absorbing vitamin B12. Okay? And so again, easily reversible, treatable condition. People just need to get B12 shots, on their muscles. Okay, so this is we can stop the decline, the damage to the brain. Sometimes even get some of the function back. And then a brain tumor, so one of the reasons why we do brain imaging is to make sure people don't have a brain tumor. And again, these are generally benign brain tumors. Okay, so they're not cancers, they're like meningiomas and so forth, that a brain surgeon can go in there and cut it out. Questions or comments about any of these? Yes, Sam?
Yes, if your mom doesn't like to eat meat anymore, does
Okay.
that mean that I start giving her B12 pills?
No, because B12 pills actually don't work. But yes, people who don't like to eat meat are going to be at higher risk. But the first thing to do is get her tested. It's a simple blood test.
What causes hydrocephalus and how to prevent it?
We don't know. We don't know, and there's no prevention. Yeah, the best way is to catch it early and treat it. Yeah. Sir?
On the vitamin B12, would that create constipation or would it help relieve constipation?
Neither. Yeah, this is why this is such a silent condition. Right? Yeah. Some people, the first manifestation is just memory problems. Now, there are other manifestations of B12 deficiency. Some people get anemic, some people can get other neurological issues, but there are some people, about a third of people, particularly older people, where the first presentation is just a memory problem. Sorry.
Does it mean, it's probably a little bit outside of this topic.
That's
Does it
okay.
mean that we can just take multivitamin at early age, take it daily, and just
No.
hopefully we can reduce a lot of those things?
No?
So you are not advocate for multivitamin?
So there have actually been studies that have looked at that, and yeah, one multivitamin a day, for those of you who are vitamin freaks like my wife, does not do any benefit. In fact, the most recent study shows that it actually causes harm. Yeah. So, yes sir.
What?
The B12 comment, you said the pills don't help, and yet I've seen it prescribed a lot.
Yes.
So tell me why they don't work, or what's the story?
The reason why they don't work, like I mentioned, is as we get older, okay, our stomach lining atrophies, okay, and our stomach lining produces a compound, a binder, okay, called intrinsic factor, okay, that then binds to the B12 so that our intestines can absorb it. So as we get older, we produce less and less of that intrinsic factor. Right? So the oral absorption of vitamin B12 as we get older, it becomes less and less reliable. It diminishes. And this is why vitamin B12 deficiency is a condition of the elderly. Because when we're young, we produce enough of that intrinsic factor. Okay? There is also a small percentage of the population that have a cell membrane transporter that is not as active as normal. And those people are particularly susceptible. They don't, even when there's enough B12 in the blood, they don't actually bring it into the cells as well. And so, yeah. So there's a lot of factors that can go into B12 deficiency for a particular individual.
Is there a test to detect a deficiency in vitamin B12?
Yes, well, the simplest test is just a blood test to check the level in the serum. But there's also other tests to check for what they call byproducts. And if there are accumulation of the backup products, that's also another way to diagnose it. So for those of you who are maybe interested, it's what we call methylmalonic acid and homocysteine levels to check for what we call functional B12 deficiency. Yes, ma'am. Oh, sorry, Dad.
Oh, yeah.
Thank you.
Who do we go for a medical checkup? Not family practitioner, is it?
Well, no, you can start with your family practitioner, but I just have to warn you, the average family practitioner has had very little training in dementia, and that's why most of them will refer you to either a geriatrician or a neurologist, somebody who's a dementia specialist. But you need to ask for a dementia specialist. Okay? Yeah. Okay.
Is B12 in the blood work, is that a normal item that they would check for on a general checkup?
No.
No? Okay.
Yeah. Yes, ma'am.
Could you maybe say one more thing about the multivitamin?
Okay.
And like why, yeah. Why, what
You mean for younger people?
for anyone.
For anybody, well, so that's a controversial subject. I'm not a real expert on that. I can't even convince my own wife, so. Yeah, so that's something you probably should talk to your primary care doctor about for yourself individually. But in general, the studies show that there's not been any benefit, actually for all age groups.
Yeah.
The only exception to that has been with pregnant women. So vitamins for pregnant women, clear evidence of benefit for the fetus. Yeah.
You said there might even be harm by taking it? What was the harm?
Well, I'm not an expert. That's not the topic of this lecture, but we can talk about that later if you're interested.
I'll do that.
Yeah. But the biggest harm, okay, is the cost. And for all elderly people who have to take a lot of pills, okay, the biggest cost is what we call pill burden. And what ends up happening is that then the older person doesn't take something they really need to take, okay, because they're popping that pill that they don't need to take.
Does that also kind of cause like overdose of particular vitamins and kind of makes your health worse for certain parts of the bodies?
Well, yes and no. So, the average multivitamin, and I know we're going off tangent here, but and we're going to run out of time soon, but the average multivitamin, the amount is teeny tiny. So you're not going to overdose on any particular, I mean, you can't, so there are conditions of vitamin overdoses, some of which can actually cause confusion, but yeah, it's very hard to overdose on a multivitamin.
But if you like taking a particular like vitamin, like high dose of like calcium or vitamin D or something, it could damage.
It could damage, right. You can't, again, all the vitamins have been known to, if you take huge amounts, even vitamin C, to cause toxicity. But yeah, an average multivitamin, you're not. The problem, but the answer is, everybody seems so interested. The answer to the question is, what happens is most people who pop a multivitamin, okay, is they think that they're covered, then they don't eat a balanced diet, they don't go out and exercise, they don't do the things, they think that popping a pill will protect them and save them instead of doing the healthy activities. Okay, that's the short answer, so that we can then move on. Any other questions? All right, so we talked a little bit about the definition already, right? Progressive degenerative brain disease, okay, impairs functioning in at least 2 cognitive domains. So wait a minute, did I jump a slide? Yeah, I did. Okay, so the most common form of dementia in the United States and around the world is Alzheimer's. The second most common is what they call vascular, or in the old days used to be multi-infarct dementia. And what this is caused by is multiple tiny little strokes that occur over a long span. Right? And the reality, from what we're finding, from autopsies, for example, is that these two tend to overlap. So there's a lot of what we call mixed dementias. And then, as somebody alluded to earlier, Lewy body dementia, which we can talk about more if you're interested. But this is a condition where people do develop Parkinson's symptoms, not the disease, but Parkinson-like symptoms, okay, along with the memory problem and along with what we call psychosis, meaning they have hallucinations and delusions. Okay? Yeah, and the difference between Lewy body and Parkinson's is that in Parkinson's disease, the dementia occurs late. So typically, after they've already been diagnosed with Parkinson's for 10 to 12 years, okay, and when people develop dementia on top of their Parkinson's, like I said, it's usually a late finding, and usually it means that they're in what we call end stage of their Parkinson's, meaning they're ready to go on hospice. Okay, so most frequent, most common is Alzheimer's. Second most common is vascular. Third most common is this Lewy body dementia. And the Lewy body dementia, again, the first manifestation could be either the memory problem, it could be the Parkinson's symptoms, or it could be the psychiatric condition. So these patients can first present to a psychiatrist, first present to a neurologist, or first present to their primary care doctor or a geriatrician for the memory problem. But usually within a year, all three of those things have occurred, and that's how we usually make the diagnosis of Lewy body's dementia, is when we see that constellation of those three things occurring within a 1-year frame. Questions or comments about Lewy body dementia or any of these before we get to frontal lobe dementias? So the fourth most common in the United States is something called frontotemporal lobe dementias. The most common of, or most probably well known of this is something called Pick's disease. Okay? And unlike Alzheimer's, Pick's disease occurs primarily first with a personality change. Before they develop significant memory problems. They also pick up other sort of funny behaviors. They develop this oral fixation. So it's sort of like, how babies stick everything in their mouth. They start doing that. They start licking things. They also have a fixation like with ice. But the biggest thing that most families notice is the personality change and an impairment of what we call executive functioning, meaning the ability to sort of put things together, piece things together. So doing high functioning things like driving, multitasking, things that require you to juggle multiple things at a time. Questions or comments about, yes, sir?
So if mom has mild memory loss, is it beneficial, go ahead and take mom to see a dementia specialist and do a blood test or all the necessary tests to prevent something bad from happening?
Yes. So the reason to get the medical workup is twofold. One, like we alluded to, is to make sure there is not a reversible cause. Okay. The other reason is to make sure you get the right type of dementia diagnosed. Because like you said, some of these, we may be able to prevent the progression or reduce the progression, not prevent necessarily, but reduce the progression of dementia. Okay. For example, go ahead.
So I don't wait until mom cannot find her way home. And then
Yeah, so particularly like the vascular dementia. So again, the most common Alzheimer's, second most common is vascular. And why it's important to be able to distinguish the two is because a lot of the vascular dementias, we can treat. the underlying cause. We can't stop it, but we can slow it down. So for example, if people are having multiple small strokes because they have a heart arrhythmia like atrial fibrillation that's throwing little clots up to the heart, we can put them on blood thinners to reduce the risk. Not eliminate, but we can cut the risk of these small strokes going up to the brain by 50%. Okay? So you can slow down the progression of the disease. Okay? Or, so for example, studies have shown just even controlling the blood pressure, okay, you can slow down the progression of the vascular dementia. Okay? So that's why it's important to be able to distinguish. So traditionally speaking, Alzheimer's is this steady, slow, smooth decline, whereas vascular dementias, because like I alluded to, it's teeny tiny little strokes. I mean, they're supposed to have the stepwise decline. The reality is in the United States, because of our sort of broken family or disjointed family that's scattered all over, right? It's hard to distinguish this. Right? Families rarely live with older people every day, so they only see them on Easter and Christmas and Thanksgiving. And then, when grandma gets lost in the airport, it's like, oh, what happened? So even an Alzheimer's patient can look like, they're having drastic stepwise decline. Or vice versa, a vascular patient, their decline could be so little, right? Their strokes are so teeny tiny every time that it's hard to notice month to month, week to week, even day to day. Yes, ma'am?
What does the little tiny stroke look like? I mean, how do we recognize that it's stroke?
Yeah, well, that's why you can't. That's why you need a workup, right? That's why we get an MRI of the brain to look for those little strokes. Yeah.
And that can be removable, that can be stopped or slowed down?
Slow down, not stopped, right? So, for example, if we find those little strokes in the brain, then they do a heart workup or they do a workup of the carotids. Okay, so for example, a vascular surgeon can do a bypass of their carotid, okay, so to reduce the stroke risk. Again, this is a condition where there's what we call atherosclerosis, okay, damage of the lining of the blood vessels throughout the entire body. This is not just something happening in the brain. All the vessels in the neck, the major blood vessels. And so we can slow it down, we can reduce the risk, but we're not going to eliminate.
So probably when the patient lost some portion of the memory, short-term memory, then that's probably the time to look for this.
Yes, right. That's why it's important to catch it early. Yes, ma'am.
Is atherosclerosis what we used to call a generation or more ago, hardening of the arteries?
Yes, hardening of the arteries, correct.
I mean, you don't hear that anymore, but
Yeah.
my grandmother would say,
Yeah.
oh, I had hardening of the arteries.
Right, so yeah, every time you eat that burger, But yeah, so same thing's happening to your heart, right? And that's why most people with this condition have heart disease as well as all the other vascular diseases.
Well, it's just so, is memory loss really the key thing to look for? Or are there other things that will show?
Yeah, that's why, there are other things that will show. That's why, again, you need a good medical evaluation to see if they have other neurological impairments. But the memory problem is what most families notice and deal with.
So if you don't see the memory, what symptoms would present themselves that you would say, okay, this is the time they need to get the workup done?
Well, again, it depends on the type of dementia, but the other major dominant issue that most families notice, particularly early on in the disease, is what I alluded to called executive functioning. Right? They lose their ability to do complex tasks. So most families, for example, notice it when people have difficulty driving, right? So they get lost, or they run over things, start getting into car crashes and things like that. or they're pulling the car out of the garage and hit the mirror or something like that.
Are they pretty far gone at that point or no?
No, those are
Okay,
usually
so that's
pretty
the
early.
early stage of it.
Right.
Okay.
Or the other thing that happens is that the older adult will just stop doing those complex tasks. Right? All of a sudden, mom doesn't do her gardening that she used to like to do, or mom stops knitting, or stops doing her favorite tasks and hobbies because she realized that it's too complicated for her.
And she might not admit it.
She won't admit it, right?
Right.
Yeah.
Yeah, that makes sense.
And again, the other difference between Alzheimer's and vascular dementia is that Alzheimer's patients generally don't have much insight into their deficiency. Right? They're happy-go-lucky, and it's no big deal, and they just tend to let things go. Vascular patients do tend to recognize the deficiency because, again, they have only some parts of their brain that's damaged and other parts of their brain that's intact. So again, one of the ways to differentiate between Alzheimer's and vascular dementia is to do what we call neuropsych testing. Right? So a neuropsychologist sits down with them. They do this 3-hour battery of tests to test the different parts of their brain, what we call the different cognitive domains. Right? And then you get a report that looks like this. So in Alzheimer's, their score will be relatively flat across all the domains, meaning it's pretty global and even throughout the entire brain. Whereas vascular, they'll have some areas that are still very good and some areas that are really bad. Right? So the other reason to be able to differentiate this is because vascular patients are more aware of their deficits, they actually are higher risk for depression. So that's one thing. The other thing is also, the good news about vascular dementia is because they have areas that are relatively intact, they can compensate. So they can be taught how to compensate. As you heard the talk, our plenary session this morning, they learn how to compensate for the other parts of the brain that are impaired. And they can be trained to do that. So an occupational therapist, for example, a speech therapist can work with them to adapt. Is there a question back there? No? Yes, sir.
So, are people who have normal level of LDL, cholesterol, triglyceride, blood pressure still at risk for minor strokes and vascular dementia?
Yeah, I can. So again, it depends on what else is going on. So if you, like I said, if you get an arrhythmia like this atrial fibrillation, so for example, my pastor, our worship pastor at church, he was very fit. In fact, he used to beat me at tennis, and which isn't saying much, and he had no medical problems, right? And all of a sudden, he develops this atrial fibrillation. And started getting dizzy and stuff like that, and went to the hospital. They made the diagnosis. So yeah, you can be relatively young and healthy. I mean, we have women who develop atrial fibrillation during their pregnancies. So
Because normally people don't routinely do MRI, right?
Right.
Do blood tests.
Yes, sir.
I've noticed with the vascular, some people will have memories that they can remember from a long time ago. And like blocks where they can't remember anything back then. It almost seems spotty.
Correct.
Is that typical
of? Yes and no. So again, depends on the type of dementia. But most people with dementia tend to lose their memory backwards. So like you said, they can remember stuff that happened 20 years ago, but they can't remember what they had for breakfast. Yeah. So as the dementia progresses, their memory tends to be lost in a retro progression. So for example, they'll forget the names of their grandkids, and then forget the names of their children, and then forget the name of their spouse, and then forget the name of their siblings. Questions, comments? No? Okay, so a little bit about, since we're on the issue of progression, about the sort of stages of progression of dementia. So when people have mild dementia, right, they have, so I'm sorry, this column I should explain is their cognitive test score, right, what we call the mini mental status, which most doctors, even primary care doctors, should be trained how to do this, what we call mini mental status exam, right, and that is a 0 to 30 score test, right, so above 27 is normal. Right? If you are below 25, you have a dementia. So people with mild dementias, they can still do some of those advanced activities of daily living, like we were talking about, gardening, driving, those kinds of things. Okay? And so obviously they can live at home with a little bit of help. People with moderate dementias are people who need a caregiver. Because at this point, they are not able to do what we call intermediate activities of daily living. And these are things like shopping, keeping their checkbook, those kinds of activities out in the community. Right? People with severe dementias usually at this point need to go into some sort of care facility. Because now they're having difficulty doing their basic activities of daily living, okay, such as brushing their teeth, okay, taking a shower, right? Even like answering the phone, things like that. And then when they get to advanced, then most of these folks are having to go to a nursing home. Questions, comments about this? All right. Let's move on to the next case. 68-year-old who just got diagnosed with vascular dementia a few months ago has had a rapid decline in function in the last few weeks. Now she's sleeping a lot during the day. She's not interested in doing activities. She's eating less. She now gets anxious for no reason, is easily agitated and irritable. I heard somebody out there was talking before the session that...
Yeah.
Okay, why'd you say that?
Because that's exactly the symptoms I see, is see them treated, and 2 weeks later they're doing fine.
Okay.
What was the answer?
Urinary tract infection.
Yeah. Screening for depression.
Screening for depression. Why do you say that?
Ticks off changes in sleep, changes in activity.
Yeah.
Changes in anxiety.
Yeah.
Changes, yeah. Those are all things on my mental list for, is this person depressed or not?
Right. So depression in a demented person manifests very differently than depression in a cognitively attacked person. Okay, and can, like you said, this is the classic, typical constellation of things. So yes, it could be an infection, which we'll come back and talk about. The other possibility, since we've already been talking about vascular dementias, is that it could be a stroke. So when you bring somebody like this to a primary care doctor, the first thing they got to think of, and rightly so, okay, is to rule out a stroke. Having said that, though, that's actually statistically low. So even though the doctor panics and orders the MRI and things like that, which is fine and appropriate, okay, especially if there are other neurological issues like what we call focal weakness, or weakness particularly on one side or one limb of the body, or swallowing difficulties or vision change or imbalance, okay, then yes, brain imaging can help. A CAT scan is pretty much useless. You need to get an MRI. Okay? Yeah, a CAT scan, all it does is to look for bleeding. So if you take them to the emergency room, all they want to do is make sure there's nothing immediate, that life-threatening that they have to deal with, and then they'll send you home. So delirium is what we're talking about when we talk about the urinary tract infection. Okay? And again, delirium can look like depression, and delirium can do all of those things we just talked about. Right? The only difference is delirium is reversible, it's treatable. Right? The major problem with delirium is an impairment of concentration or attention, what we call sensorium. or level of consciousness. But it can be caused by lots of things, most common being an infection, like a urinary tract infection or a pneumonia. The other thing that can cause it is underlying heart disease. Okay? So what we call cardiac ischemia, the heart not getting enough blood. And that, again, that's a precursor to having a heart attack. So one of the reasons why it's important to catch it early is then you can actually prevent the permanent damage to the heart. Okay? But you also want to look at recent changes in medications and then any lab abnormalities, including the ones we've already talked about. But even simple things like calcium or potassium changes or sodium changes can cause this degree of confusion. Right? The biggest culprit in the United States in terms of medications is sleeping pills. Okay? That over-the-counter Benadryl or Ambien can cause a lot of this as well. Questions or comments? Yes, sir.
What was the definition again of delirium?
The medical definition of delirium is an impairment of what we call sensorium, or level of consciousness. And that gets manifested in the ability to concentrate or attend to a task. Okay?
So you're not able to focus in and...
Right. So it's what we call registration. So unlike dementia, where the difficulty of the brain is retrieving the information, okay, in delirium, the information never gets in there to be retrieved. So that's the difference. Okay? Not so again, a lot of times I've had a lot of families of delirious patients come up to me and say, oh, they have a memory problem. Well, it's actually not a memory problem. Okay? It's a registration problem, meaning the information never went in to be retrieved.
But if it's tasks that you already know how to do, then that information is in there, but you're saying it doesn't get in. When you say
Right. So if you can remember the last time you had a bad flu, right, and how foggy your brain was, and that's what it's like. Yeah. Okay. And what we see on the clinical side is the difficulty in attending to a task. And that's what we test for. The way we make the diagnosis of delirium is we actually test for people's concentration and attention. But even without doing the formal testing, when you just talk to them, you'll see they go off on like tangents and, when you ask them a question, they start answering your question, but halfway through they're floating off to, something else. Yes, sir?
What do you think about melatonin?
Melatonin is pretty harmless. It doesn't do much for insomnia, particularly chronic insomnia. What melatonin is good for is jet lag. So for patients or for people, and this is not just older people, but even for younger people, obviously, if their sleep-wake cycle is thrown off, then melatonin can help you shift that back. But if you have a primary insomnia, not related to jet lag or shift in your sleep-wake cycle, then melatonin's not going to do anything.
Then what do you do?
Huh?
What do you do for that kind of patients?
Well, so that's another talk out of itself. Insomnia is another hour-long talk. But to answer your question quickly, particularly for older people, it's trying to figure out the underlying reason for the insomnia. Okay. What happens with most families, and even with most primary care doctors, is they just treat the insomnia. They just try to cover it up without doing the work of digging to find out why they have the insomnia. So you want to try to figure out why they're having the insomnia. So is it their anxiety? Is it their depression? What is it? Are they having pain? Why are they having the insomnia in the first place? Okay. Yeah, so don't just throw a sleeping pill at them.
It's probably a general question. What is considered dementia versus getting old, be forgetful?
Right.
Even at my age, not really old, but I'm not as sharp as I used to be.
Right. So I think what you're asking is, how do you tell dementia from normal decline of aging, right? So first of all, like I mentioned, the answer is an impairment of function to such a degree that it impedes your daily life. So, like for example, you're able to compensate. And most older people, as we get older, are able to compensate, right? So yeah, we may put more, Post-its on the fridge, or like our morning speaker alluded to, put more reminders on our phone, or we pick up these adaptive techniques, okay? But demented people are not able to do that, no matter how many adaptive techniques they try. Okay? The other way to put it is that a normal person, like if you forget something and I give you a clue, a hint, right? You go, oh, yeah, I got that, right? So again, like our morning speaker said, the spouse nudges them and says, it's Jack, and oh, yeah, okay. Then they remember. But demented people, you can give them as many cues and clues as you want, they're not going to remember. Okay? That's the difference, right? So if a normal person, yeah, I forgot my car keys, it may take me 20 minutes to go find them, but you eventually find them, right? That's normal. Right? Demented person, they'll never find their car keys. They could search for 2 or 3 hours and they'll never find their car keys. Huh?
No, eventually they'll give up.
They'll give up, right? Yeah.
They'll forget that they were even.
That's the beauty, right? All right, so geriatric depression screening, that was so it's important, again, because it's so easy to miss depression in older people, particularly demented people, okay? And because, again, how do you tell between all these other things that are going on? The way to do it is to do standardized screening. Again, because it's such a high prevalence in dementia, right? About 30% of people with dementia, somewhere along the stage of the dementia, have depression. So because of the high likelihood, it needs to be routinely screened for. So there are 2 common screening tests. The geriatric depression scale is what we use for people who are still verbal, meaning they can still fill out their own form or answer their own questions. Right? For people who can no longer do that, they're getting so demented, then the Cornell test is what is used, because the Cornell test is based upon the caregiver's response, not the patient's, not the elderly person. Questions?
Can we find that 15 points
Say again?
online or anywhere, the 15-point depression
Yeah,
screening?
yeah. So geriatric depression scale, there's 2 versions.
Okay.
There's the 30-1 and the 15-1, and the 15-1 is shown just as good as the 30, and it's shorter and faster to do. So I use the 15.
Got it.
Yeah. Am I going too much hot air? Is that why you're opening it? Okay. All right. Let's talk real quick about choosing an antidepressant. So the default antidepressant is what we call a SSRI, selective serotonin reuptake inhibitor. Okay, so you probably know these drugs as like Prozac, which by the way we don't give to older people because it's a first generation with lots of side effects. But other ones in this class are like Zoloft, Lexapro, these kinds of antidepressants. So they're very common and popular. When would you not use that? Well, for example, if the person has pain, and lots of older people have pain, right? And particularly like arthritis, then what we give is what's called a serotonin norepinephrine reuptake inhibitor, or the SNRIs, okay? Because these also treat pain as well as treat the depression. So you can hit 2 birds with 1 stone, okay? Remeron's one of my favorites, particularly if they have insomnia, okay? And it also is an appetite stimulant, so people who have appetite problems and anxiety, so you can actually now treat 4 things with 1 drug, okay? If they have just insomnia, none of the appetite problems, and their depression is mild, okay, then you can use trazodone. So trazodone is actually my favorite sleeping pill, not Ambien or Benadryl. Okay? Older people are not supposed to get what we call tricyclics, particularly people with dementia, because the tricyclics can actually make the dementia worse. Okay, so tricyclics are fine for young people, but tricyclics also cause low blood pressure, so then these little old people, they fall and they break their hips. So yeah, old people should not get tricyclics.
What's an example of that?
Brand names are like Elavil, generics are like amitriptyline, imitriptyline, things like that. The tryptamines.
Define old.
The United States government defines old as 65 and over. If you qualify for Medicare, you're considered a senior. That's how it's done. But to a geriatrician, chronological age is not very important. Okay? So I tell my students and residents it's a physiological age that's a lot more important. I have 90-year-olds who are still swimming 10 laps a day in the pool, whose cholesterol is better than mine. Okay? And we have 55-year-olds who have been smokers their whole life, who look like they're 90 and can barely, make it across the parking lot. Yeah, so chronological age means nothing. Okay, last case, I believe, and I will try to hurry up. So, a 69-year-old with moderate Alzheimer's, has a long history of anxiety, been on Valium for years. Spouse is 5 years younger, is still working, and so he gets agitated every morning when she leaves for work. So, how can we help?
Give him a puppy.
Give him a what?
A puppy.
A puppy? I don't know that you want to trust him with a puppy. But good idea, though.
Get off Valium?
Get off Valium? Why do you say that?
Just for years, I think, are you supposed to take Valium for years?
You are not supposed to take Valium for years. Yeah.
Could that lead to, I had this issue with my mom. She's, obviously I'm here for a reason, and she took out a long time. We got her to get off of it maybe in the last 6 months. It's not like anything's improved, but could that have lended to the problem, or
Yes.
Oh wow.
Yeah. So Valium is like alcohol. And as we get older, even without dementia, but particularly with dementia, our brains become more and more sensitive to drugs like Valium and alcohol. Okay? So the guy who could drink 2 whiskeys a day and had no problem when he was 30, his brain at 80, that 2 whiskeys a day is like 6 whiskeys a day. Okay? So it becomes, but you can't stop them cold turkey. You have to taper them because otherwise they can go through withdrawal.
Yeah, I think we probably didn't do it the right way, but she doesn't take them anymore.
Yeah.
It wasn't like supervised by, we just kind of intervened in like, what are you doing?
So that's part, I agree, so that's part of the problem. What else can we do?
Maybe incorporating her leaving as part of his routine so that he understands that she'll be coming back. Because his anxiety might be, this person's disappearing, is she ever coming back?
Right, so that may be part of the problem. The challenge though is helping him to understand. He's gotten to the point where it's going to be very difficult to help him understand. So I know we're running out of time, so let me tell you what we did. So what I didn't tell you is, yes, thanks. So what I didn't tell you is he used to be the CEO of this company, right? And so he's used to going to work every morning. Right? So the fact that his wife left to work would remind him that he wasn't going to work, and that's why he got agitated. We solved this problem just by putting a desk with a play phone and some paper and pen, and he would go to his office and play work for 10 minutes, and that solved the problem. He stopped getting agitated, then he was fine the rest of the day. He did not need to be medicated. Because people kept calling me saying, he needs a medication, you need to give him a medication. Well, we were able to solve the behavior problem without giving him a medication. Because otherwise, what would have happened would have been, we would have upped his value. So, let's talk about the do's and don'ts of dealing with people with dementia. And I know the biggest challenge that families tell me is the constant repetition, right? Saying the same thing over and over again. Okay, it's like Groundhog Day, you relive it over and over. Okay, so what we need to remember, and I know it's hard, it's not, and this is not just with dementias, but all the, mental illnesses that we're talking about today, okay, you gotta remember it's the illness, it's the disease, it's not the person. Right? So they're not acting like this because they're trying to get you or getting back at you or getting revenge for all the things you did to them for 20 years. Right? Right? So related to that, the don't side is don't confront. Don't try to correct them. First of all, it doesn't work and you just get frustrated. Okay? So yeah, sometimes you have to sort of get along, go along to get along, right? However, having said that, don't lie to them. Okay? Don't give in if it's something that's dangerous or not. Okay? But it doesn't mean you have to correct them for every little thing. Right? And this is what Curtis and Carol taught me when we did marriage counseling. Right? When I did marriage counseling with my wife, like, you can't change the other person. You can only change you. Right? So change how you respond to them. But what you can do is redirect them. Right? So it's fine to say, oh, well, let's go this way, So to redirect the behavior, to distract them and all that, like we talked about with the previous case. Most important thing is take care of yourself. Right? So sometimes, especially if the situation's bad, take a time out. Take 5 minutes out. Okay? Go pray. Go, turn on some music, whatever. Call a friend. Right? But to keep yourself calm. What you don't want to do is to self-medicate with Valium or alcohol, right? Right, but don't yell and scream. The other thing is, don't hold it in. Because I have family members like, held it in for you, and then you eventually will pop, and then it'll become like a volcano, right? So don't do that either. Don't go to the two extremes. Questions or comments about that? Yes, sir.
My own experience is that I found that taking care of dementia people is constantly apologize to other people because, for example, my father is pee on the pants or yelling at people and embarrass others, embarrass himself. It's just like very, very tiring to bring that person out or even be around because it just causes so much drama in everyday life. Every little thing can be a drama.
Right.
And it's losing patience easily. I really feel very, very sorry about the whole situation.
Yeah.
I'm making comment. I'm not sure if there's any solution to that. Sorry. Yeah.
No. Yeah. Well, not that I'm here necessarily to give solutions, but I think first of all is recognizing that frustration, right? But also recognizing sometimes that we have to let that go, meaning we have to sort of accept that. Just like when we had kids, right? And they pooped in their pants and they peed in their pants in public, or they screamed and yelled at the supermarket, right? And everybody's looking at you. You're gonna have to say,
the kids are killed.
Right. It's like, well, I'm still a good parent, really. I am. Right? So yeah. I know it's embarrassing and hard, but sometimes, we have to just accept it. It's more our issue than it is, again, theirs. But there does come a point where you have to hire a caregiver, and where you may have to determine that, like you said, it's not worth taking them out. Okay? So those are the practical decisions that you have to make. Again, recognizing this is a progressive disease, that things only get worse, not better. Okay? So anyways, pros and cons of some of these things, hiring a caregiver versus adult day health care. Okay, so sometimes you may have to say, yeah, they're going to have to go to daycare so that I can go to work. Okay, everybody wants to resort to medications. It's convenient, I totally get it, but there are also side effects. Okay, so we got to be careful. Real quick about PACE programs in the next slide. But when things get really bad, like I mentioned, alluded to earlier, you may have to put them in some sort of a facility. So PACE programs, I don't know if you're familiar with those. So PACE stands for Program for All-Inclusive Care of the Elderly. And what they provide is comprehensive medical care or health care. Right? So what most families, for example, really appreciate is actually the home care and the transportation. These sort of practical things that they will provide that Medicare otherwise wouldn't provide. Right? And the reason why these programs exist is to keep people out of facilities, from having to go to facilities. Right? And so they tend to be what we call dual eligible or Medi-Medi patients or people. Right? Because it's the Medicaid part, or in California, Medi-Cal part, right, that covers the rest of us, that Medicare doesn't. Okay, so real quickly, since we talked about medications already, yeah, anxiety medicines generally cause more harm than good. If you do have to give an anxiety medicine, there are non-sedating anxiety medications, okay, that don't cause the falls and hip fractures. Sometimes an antipsychotic is actually safer or better, although you need to know that they can increase stroke risk, okay? But if I haven't harped on it enough, antidepressants really are the best approach if you have to give a medication. So again, this is why it's important to look for depression. And then there are the Alzheimer's medications. Real quickly, the cholinesterase inhibitors, which many of you might have heard of, things like Aricept and Exelon, they actually don't do much. So I tend to stop these medications, particularly as the dementia progresses, or if they don't have Alzheimer's in the first place. Right? The dementia medication that actually does do something is memantine or Namenda. It's what we call an NMDA receptor blocker. Okay, and then finally a plug for the Alzheimer's Association. It will help you a lot if you're struggling with these things. Okay, so let me wrap up real quick because I know we're out of time. So what we've talked about is getting appropriate medical and psychological evaluation, screening for depression, okay, using non-medication techniques to manage the behavior. But the reality is, ultimately, most people need some sort of medications. Questions or comments before we finish up? Yes, sir.
After retirement, I think it's almost time for dementia to come in. How can you sort of delay yourself active?
Delay retirement or delay dementia?
Exercise?
There are not very good studies on that. Yes, exercise is one that has shown some benefit. Nutrition is sort of plus minus. But yeah, there's really nothing that has been shown to reduce dementia, especially like Alzheimer's. None of this.
If you don't retire, would that help?
Unfortunately not, no. Yes,
For the lady back there, I disagree. I've been retired 25 years, and as long as you stay active, you'll do fine.
Yeah, retirement can be fun, right? Yeah. Anything else, anybody? Yes, ma'am.
Can insomnia be an early symptoms of dementia?
No, generally not. Well, so for older people who have insomnia, the most common reason is depression. So that's like, yeah. So you really want to either screen for that, or if he's already been diagnosed, want to make sure that he gets adequately treated. Yeah. Yes, ma'am.
My question is, so our parents basically have taken responsibility of their health care. When do we go in?
Step in? Yeah, that's a complicated, and that answer really depends on your family dynamics. It also depends on their functional capabilities or levels. But if they have a dementia, that day will come. So you need to plan ahead. And the more you plan, the easier it will be. So like getting things like a durable power of attorney, Okay, yeah, having a strategy, you know, for when they can't drive. Okay, making arrangements for their care at home. So whether it's like Meals on Wheels or getting the grocery delivered or getting the cleaning done, the laundry done, all of those kinds of pragmatic things. But the sooner your family talks about these issues and plans for them, the easier it'll be. Because if you wait for the crisis to occur, it will be a lot harder. And it's not a question of when the crisis occurred, or not a question of whether the crisis occurred, but when. Okay? If they have a dementia, it's going to come. Does that help? Yes.
Going back to the repetitive
Yes.
behavior. So on your don'ts it said don't confront or correct. So my mom's at this stage where if I make her aware, she does try to stop being.
Okay.
So I think there's like a line where, but then I feel bad because I have read, that's not the first time I've seen that, where you just shouldn't say anything and it makes them feel bad, which I think it does. But sometimes it does help her not, because she will, especially if she's nervous and we're like going to a doctor, it's unbelievable how many times, and she doesn't remember every time.
Right, so let me clarify what I mean by correct.
Okay.
So what you're talking about there is redirecting. So there's a difference. Redirecting is constructive, right?
Okay.
Like you said, it's saying, Mom, this behavior is not appropriate, or Mom, let's do something more appropriate, let's do something better, okay? Versus yelling at them saying, why'd you do that? You stupid thing! So that, yeah.
Like the elder abuse, yeah.
Well, elder abuse is actually what I used to do, but that's another story.